everyone. Thank you for joining us. This is Amanda from the North Sound ACH. We are going to wait just a couple minutes for folks to join us, and we'll start right around 10:02. Thanks. Hi, everyone. Thank you for joining us for our 6 Building Blocks webinar. We have some guest speakers today, Dr. Laura Mae Baldwin and Brooke Ike from UW Family Medicine, and I am Amanda Robbins with the North Sound ACH. Some reminders to get us started. All of the participant lines are muted. If you do have questions, you can send them into the chat box. Please feel free to send them to me anonymously. If you don't want everyone to see them, you can just send them to admin, and I'd be happy to read them out. And then this recording, along with any other materials that are referenced in the webinar, will be posted to our partner portal. And then we will also start this webinar with a land acknowledgement. We begin by acknowledging with humility that the land where we are today is the territory of the people of the Salish Sea. The present is imbued in the waterways, shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people since time immemorial. And our 2 guest speakers today, as I mentioned, are Dr. Laura Mae Baldwin and Brooke Ike, both from University of Washington Department of Family Medicine. Laura Mae Baldwin is a professor at the Department of Family Medicine and a practicing family physician who is passionate about supporting primary care teams in caring for patients with chronic pain. She is one of the clinical leaders of the 6 Building Blocks program team that works with clinics and healthcare organizations locally, regionally, and nationally to improve care for patients with chronic pain who use long-term opioid therapy. Our other guest today is Brooke Ike. She is a research scientist and practice facilitator with the UW Department of Family Medicine and enjoys working in partnership with community-based public health and clinical organizations. She is also one of the leaders of the 6 Building Blocks program team that works with clinics and healthcare organizations to improve care for patients with chronic pain who use long-term opioid therapy. And so we will go ahead and transition over to their PowerPoint. So Brooke, if you want to go ahead and take the lead.
Great, and this is Laura Mae. Oh, go ahead, Brooke.
I just want to make sure I realize one thing we didn't test was how do you want me to open up my slides, Amanda? Or how do I
Yeah, you can do that, or
in.
I have your slide deck here too, and I can go through it as well.
Okay, why don't you go ahead and forward the slides so we don't have
Okay, will do.
Okay, great. Well, good morning, everyone. This is Laura May Baldwin, family doc, as Amanda introduced, from the University of Washington. And I am really excited to be here today to share about the 6 Building Blocks program, which is a program that clinics across Washington state have been implementing, and now nationally, to really address the challenges that they face in caring for patients with chronic pain who use long-term opioid therapy. And one of the things that we really appreciate about the 6 Building Blocks is it's a team-based approach to improving opioid management in primary care, as we are all working very hard to work with the teams that we have in our primary care settings. So next slide. So what is the 6 Building Blocks program? It's an evidence-based roadmap. It's really a blueprint that can help guide clinics and healthcare organizations to redesign the processes that they use to improve care and to manage opioids. It takes place at the systems level, at the clinic level. Next slide. And you're meeting two of us today. That's me in the upper left-hand corner and Brooke in the upper right-hand corner. But we have 2 other very important members of our team. Michael Parchman, who's a senior investigator at Kaiser Permanente Washington Health Research Institute, and he's really the originator of the 6 Building Blocks, and I'll tell you a little bit about how that came about in just a bit. And then Katie Osterhage, who is a fellow practice facilitator on our team. Next slide. So I'm going to share with you a little bit of a few things that you probably already know, but about where we've gotten to with the opioid crisis, and then we'll talk a little bit about where the 6 Building Blocks came from and what it looks like and how you might implement it in your practices. So as you may have heard through the news, lots and lots of Americans are dying every day from an opioid overdose, about 130 actually. That includes both prescription opioids as well as other opioids like heroin and fentanyl. Next slide. Of those 130, 46 of them are actually dying from prescription opioids daily. And the next slide talks about the number of opioid prescriptions written for every 100 people in 2017, which is the latest data that is available. So 59 opioid prescriptions written for every 100 people in 2017 across the country. And the next slide shows that we're pretty much on par with that in Washington state, about 57 opioid prescriptions written for every 100 people in our state. And the next slide shows how primary care providers are actually the top prescribers for opioids. And this is data from National Medicare. This is National Medicare data. So we really feel like the 6 Building Blocks, which has up to this point targeted primary care practices, is a great place to start because it starts at the source of where many of these prescriptions come from. So the next slide really illustrates that we were thinking that a new approach is really needed to addressing the opioid crisis, and that's where the origin of the 6 Building Blocks comes. And the next slide talks about how this really came from primary care practice. That's one of the things I love about it. We didn't make this up. Actually, what happened was Michael Parchman, who I showed you the picture of earlier, had a grant from the Robert Wood Johnson Foundation, probably about 6, 7, maybe 8 years ago now, called LEAP, or Learning from Effective Ambulatory Practices. And this study was actually not about opioids at all. It was about learning from practices that were felt to be exemplary in their implementation of team-based care. And so they identified 30 practices across the country that were supposed to be exemplars in team-based care, went to them for a week, and basically embedded themselves in the practices, talked to people there, watched what they did, learned from them. And what they found was that this was even before the CDC opioid guidelines came out. 2/3 of them were using the team-based skills that they had honed so well to address opioid management in their practices. So Michael brought the data back from those practices. And on the next slide, we shaped that into these 6, actually the slide before that one. We shaped that into, just go back one slide. into the 6 building blocks. And we actually took those learnings and packaged them into these 6 elements. And we've published that in the Journal of the American Board of Family Medicine. Now I'll just tell you a little bit about what those 6 building blocks are. So the next slide starts with the first 3 building blocks. And those building blocks are things that will be familiar to you, that probably would make sense in terms of how to affect change in a practice. First is these practices had demonstrated leadership support, and they built organization-wide consensus to prioritize the fact that they wanted to more selectively and cautiously prescribe opioids for their patients with chronic pain. Second, what they were doing was they were, to a T, identifying the fact that they didn't have clear policies in place to address opioid management. So they revised if they had policies, or created if they didn't have policies, policies that addressed chronic opioid management. They created patient agreements that linked very closely, that aligned closely with those policies. And then importantly, they developed workflows that were based on these policies so that it was clear which team members were responsible for which elements of implementing the policies. Third, they figured out who their patients were with chronic pain using long-term opioid therapy, something that's not possible in many practices up to this point. And they started to track and monitor them. And this was important because it allowed them then to proactively manage the population of patients using long-term opioid therapy. They could do so before, during, between clinic visits. And this was a very powerful tool. Next slide. The fourth building block was that they used that tracking and monitoring system to plan for their visits, as I mentioned. So they prepared as a team, sometimes in huddles, for example, beforehand, looking to see what it was that that patient was not up to date on. For example, urine drug testing, or having the prescription drug monitoring plan or program checked, or was there any decalculated? So they were able to plan for clinic visits, and they knew that at those clinic visits, there could be conversations that might be difficult. And so they supported empathic communication for these patients by training staff and their providers so that they could have patient-centered communications. The fifth thing that they did was they recognized that once they started implementing their policies, their patient agreements, and their workflows, they recognize that many of these patients are complex. They may have comorbid mental health conditions, depression, anxiety, PTSD. They may actually have opioid use disorder, and those conditions need other treatments. So they needed behavioral health therapies, or they needed treatment for opioid use disorders such as buprenorphine or methadone. And so they set up ways to either provide those services themselves, or referral pathways that allowed them to both identify patients with these other conditions as well as to refer them to their needed care. And finally, these sites actually measured their success. They were continuously using their tracking and monitoring systems to be able to identify whether they were reaching their goals, and if not, they'd make some revisions and try again. So that gives you a sense of the 6 building blocks. The next slide. Once we had these 6 building blocks in place, we realized, well, gosh, okay, we know that these clinics did these things, and they were fairly uniform in the types of things they put into place. But if we take these 6 building blocks and put them into place in new clinics that don't have them, is that a successful way to manage opioid and improve care? So we obtained funding from the Agency for Healthcare Research and Quality for a research project that took place in 20 rural and rural-serving clinics in 6 organizations in eastern Washington and central Idaho. And this was conducted between 2015 and this year, 2019. And what we did was we provided external support or practice facilitation or coaching for 15 months to these clinical organizations to help them implement the 6 building blocks. Next slide. So what did that mean? How did we support them? First, we helped the clinics form their own opioid improvement teams. Each clinic or each clinical organization formed a team that had a clinician leader, that had some person who could take the lead in the improvement process. It could be a quality improvement person, it could be a clinic manager, it could be a clinician lead like a nurse manager or a particularly respected medical assistant in the clinic. And then we had an on-site in-person team building kickoff event in which our team of clinical leads and practice facilitators went to the clinic, and we conducted a clinic-wide self-assessment of the 6 building blocks. This was a wonderful event in which the clinics basically got small groups together of all the different providers and staff and administrators across the clinic, and they broke into small groups, and they looked at themselves and said, how are we doing on these 6 building blocks? And that allowed them to really get a sense of the baseline and the degree to which there was consensus or not on how things were going in their clinic. And after that kickoff event, we met with the opioid improvement team, which used what they learned from the kickoff event to stimulate the development of their first 3-month action plan. What did they want to do over the next 3 months to move towards more fully engaging with the 6 building blocks? So the next slide talks about more support that we provided. We basically conducted monthly check-ins and then quarterly coaching calls. These were all done virtually, in which a 6 building blocks practice coach like Brooke and clinician support and clinician like myself or Michael Parchman basically worked on action planning and problem solving. We supported the clinics as they did the work of revising their policies and patient agreements to ensure that they were evidence-based. Once those were in place, creating workflows to support those policies, to develop a tracking and monitoring approach. And then this was a tailored process. So each clinic started in a different place. Each organization started in a different place. So they might want to take on other work. They might have started with some baseline policies and wanted to improve them. They might have started with some workflows and wanted to revise those. They might have started with some tracking and monitoring resources and then just adapted those. And then they also could take on other work like the patient-centered training, communications training, or developing other resources for opioid use disorder or behavioral health conditions. Next slide. We also held monthly shared learning calls at which the clinics got together and they shared the lessons that they learned, the challenges they were experiencing, and shared solutions with each other. So they basically did a lot of collective teaching on what was working for them and how they did things. If they created materials, they would share that across the clinical settings. We organized monthly webinars and case presentations with a pain specialist, so they were able to learn didactically for a short time about pain management, but also to share about patients that they were having challenges with managing and how to do that best. And we had many shared resources, and we have even more now: model clinic policies and patient agreements, clinic workflows, patient education materials, and so forth. So what happened? Next slide. What we found was that at our clinics, and we have just published this in a report that came out, an article that came out this month, that the number of patients using long-term opioid therapy and of those who remained on longer-term opioid therapy, the proportion on high-dose opioids decreased in our clinics, and the link to that is at the bottom of this slide. Next slide. And importantly, we found other findings about the work life of the clinics, and this really impressed us. We found that after implementing the 6 building blocks, the clinical teams that we worked with reported they had more confidence and comfort in their clinical practice with patients who had chronic pain and used long-term opioids. Their relationships improved with these patients. The collaboration and teamwork within the clinical site increased. And they had a number of external administrative requests from insurers and governmental agencies, and they were able to respond to them and say, hey, we're doing this work, we're putting this into place. The next few slides just give you some quotes from some of those who adopted the 6 building blocks. So in terms of increasing confidence and comfort, one provider said, I feel confident managing my patients, my pain patients with or without opioids. The 6 building blocks program gives you a confidence level that you're doing what's best for you and your patients. And another provider said, now I've got a defined care pathway for this emotionally charged and complex area of care. I'm walking in with a plan. It's like walking into an emergency room and someone's having a cardiac arrest. That's actually not the most stressful thing that I do because there's a clear plan, and now I have the same kind of pathway for opioids. Next slide. And in terms of decreasing stress and providing care to patients using long-term opioid therapy, a quote that is, everybody that works in this clinic says to me, do you remember how much turmoil there was around this? Wow, we don't have any of that anymore. And that's because the consistency across the clinics really increased in terms of how different providers manage their patients. And the next slide talks about improving relationships with patients. A quote that said, patients really align themselves with it. And so many of them told me, gosh, I feel so much better. I still have pain, but it's no different. And that was a surprise for that staff member. Or the thing that surprised me was the number of patients that once they started and understood our standard care pathway, they said, wow, I get it. And then a lot of them just started to taper themselves ahead of us. I wasn't prepared to see the patients engage so much. And finally, again, around improved relationships and reducing kind of the negativity of the emotional interactions. A provider said, I used to have so many confrontational appointments where I'd have to have nursing staff standing outside the door because it was such an issue, someone calling me an evil doctor who wouldn't prescribe narcotics. And now everybody's on the same page, and it's just an accepted philosophy of care with staff, providers, and with patients. So I hope that gives you a sense of kind of the sense of relief that we had from the 6 building blocks program. It just really has made us incredible enthusiasts and boosters for the program, as you can imagine. One of the things that I really appreciate about the 6 building blocks is how complementary it is with medication-assisted treatment programs and managing opioid use disorders. Some of our clinics, oh, sorry, next slide. Some of our clinics have worked first on addressing opioid management for patients with chronic pain and long-term opioid therapy, and that has led them to identify that they're patients with that they have patients with opioid use disorder and that they need MAT programs or medication-assisted treatment programs in place. But other clinics have come to the 6 building blocks program because they put MAT programs in place and realized, wow, we actually need to manage opioids in a different way in our clinic, and so it can work in both ways. Next slide. So we've heard that a number of you at North Sound are interested in implementing the 6 building blocks. And so I thought I would just touch briefly on some ideas, and then I'm assuming that what will follow, and Brooke's going to actually give a kind of a walkthrough of our website, which has a lot of resources, but I'm assuming what will follow is plenty of questions and conversation about how that might happen. But I thought I'd just touch on a few ideas. One of the things that clinics have told us is that the external coaching support was really critical to their success. As I mentioned, implementing the 6 building blocks involves kind of a tailored set of activities that was provided by practice coaches that are really trained with skills that are specific to the materials in the toolkit. And you can see in this slide, there are kind of 3 phases. There's kind of a prepare phase where clinics are actually learning about the evidence, guidelines, and regulations related to opioid management. And then they're forming their own opioid improvement team, building leadership and support, doing their baseline assessments, identifying their priorities, and really generating that consensus across the clinic. That's usually a 3-month time frame. In the second stage, there's the real work of that opioid improvement team in collaboration with their clinic, where they're using this 6 building blocks approach to redesign the care in a way that fits for them. So it's really tailored to what the clinic wants to work on. Most clinics begin with policy and patient agreement revisions, and then throughout that process, they are constantly reassessing and deciding where they want to go next and which building block they want to work on. And that is usually a process of about a year's time. And that's followed with a very short phase in which the clinics then sort of take stock in what they've done, how far they've gotten. They look at what they want to sustain, how they want to continue to incorporate making these kinds of changes and assessments long-term. And there's this time of kind of making some decisions about how they want to sustain and move forward from there. Next slide. So I think that thinking about your clinics, one of the things that you might want to think about is how to identify and support a coach who might be able to work across your practices to support implementation of the 6 building blocks. I don't know enough about your different practices, and that's something we could certainly talk about and kind of brainstorm about to think about how that might work. That you might have a QI lead within each of your practices that would support the implementation of the 6 building blocks in your practice or in your organization. And you may have a coach within that group who could coach across practices or in one of your the hospital organizations that you work with. I don't know enough about your organization, but again, we can talk about that. Our team does have a coach training program that can train your coach or a QI lead in the 6 building blocks work if that became of interest to you. So that's what I wanted to just share briefly. I think, Brooke, you're now going to, on the next slide, and I suspect that you may need to take control now of the slideshow. I'm going to take a tour of our website, which has a lot of resources for you and for anyone who wants to take on this work.
Okay, great. Hi, as Amanda introduced me earlier, my name is Brooke E.K., and I am a research scientist and a practice facilitator here at the University of Washington in the Department of Family Medicine, and I've been working as a practice coach with clinics using the 6 building blocks program now for, I think, 4 years since its inception, and I really love this work because it's just inspiring to see all of the different creative approaches that clinics are able to take to tailor these team-based approaches and system-based changes to where their organization is at. And I just think it's a terrific opportunity that I've had over the last 4 years. So what I would like to do is share with you about our 6 building blocks website, which is at www.improvingopioidcare.org. We have worked very hard to be able to make this program as accessible as possible for others through this website. And so I love when I hear that people are using it. So I wanted to give you a quick tour so that hopefully you'll find that there might be some tools and information that would be useful to you. I wanted to check to make sure. I've just shared the screen. Can you all see the website now and my mouse moving around?
Yes.
Perfect. Thank you, Laura May. So I'm just going to walk you through the various tabs that you see on the top. This home page obviously just gives you an introduction to what the 6 building blocks are, who the audience is for this website, and what you're going to find on the website, which is really tools and resources for anyone who's looking to improve care for their patients with chronic pain on long-term opioid therapy. The 6 building blocks tab gives you an overview of the 6 building blocks, like Laura May did as well. It also has links to the article of the development of the 6 building blocks and the results around opioid prescribing for clinics who implemented the 6 building blocks. And also within each of these building blocks, it gives you a little bit more detail about why we think and what we've learned from other clinics about why this particular building block is important, some example activities, examples from clinics we've worked with on how they implemented it. And then there are drop-downs with self-assessment questions about where your organization is within this building block and resources that might help implement improvements within this building block. So these exist for each of the 6 building blocks. I mentioned the self-assessment and how in the drop-downs for each building block there are links to those questions. This self-assessment is really a tool to initiate discussion within the clinic about what's happening right now around how we're caring for patients with chronic pain on long-term opioid therapy, and to start thinking about where the clinic might want to be going forward and what are prioritized areas for work. So when we implement the 6 building blocks alongside clinics, we suggest that their opioid improvement team, that team who's really championing the work at the organization, completes the self-assessment as a team to sort of use that as a discussion point for figuring out what the priorities for the work will be. And then also at that kickoff event that Laura May mentioned that we do with all members of the clinic, staff and clinicians, we do it as a small group activity, which is really fun because there's a lot of conversation. It's fascinating to see the differences in perception of where things are at, and it really helps the team, the opioid improvement team, figure out next steps for the work. So on this page, you can download the full self-assessment as a PDF, but we also have the questions here on the left within each building block, as well as a score guide, and then these challenges and successes discussion guide, which is sort of additional questions to think about before really diving into this work. The next tab is the implementation guide, and so this is giving you a sense of how we've laid out and how we have done this program with clinics over those 3 stages that Laura May mentioned, and then gives more details on the left here in these tabs for the kinds of activities that clinics do in these stages. So for instance, in the prepare and launch, building an opioid improvement team, learning about existing evidence and guidelines, hosting the kickoff, et cetera. And so there are also some links to resources to support these activities. So there are activities for each of these stages that clinics generally are engaged in working towards achieving when they are implementing the 6 building blocks. And there are a lot of them, which is part of the tailoring process for clinics to figure out, based on their foundational work of assessing their baseline and what their priorities are and what are important to them, they're able to figure out what do we want to be doing first. You know, we want to focus on revising our policies. It's really important to us that we have a dashboard of key measures about our patients, so when they come in, we know their status and we know how to provide the best care for them, et cetera. And then they make a plan, and we work with them every 3 months and along the way as they need it to make sure that the ball is moving forward. The helpful resources tab is probably what I think most people spend the most time in if they're using this website. So within this tab, we have resources for clinics. We have a set of recommended clinical tools, assessments, and we have resources for practice facilitators, or this could also be other kinds of coaches or quality improvement leads within clinical organizations who want to implement the 6 building blocks program within a clinic. So I'm going to show you some of this. In the resources for clinics, it's divided out by building block, and these are the same resources that are on that 6 building blocks page as well. So we have tons and tons and tons of resources to support clinics who want to do this work. So for example, we have a example model policy that aligns actually with Washington State 1427 and the CDC guidelines that many clinics use when they are thinking about the kind of changes they want to make to their policy. We have example workflows. We have data to consider tracking. When you're building a tracking and monitoring program, what different variables might a clinic want to know about? We have lists of opioid names and sedative names. We have patient education examples, scripts for providers and scripts for staff for those difficult conversations that are inherent in this work with patients with chronic pain. It's just really challenging, and scripts can really be helpful, along with lots of training resources. So there are empathic communication resources here and self-management resources, et cetera. So there's just a whole wealth of materials here. I highly encourage you to take a look and explore and see what might be useful for you and your clinic. Another useful set is these recommended assessments. So these are all a part of suggested clinical tools that are in the example policy. This table lays out sort of what the assessment is covering, and then tools, how to assess it, what to use, the PEG, CALM, stop bang, et cetera, with links to the tools themselves, and then how frequently to do these assessments. And these are, again, in alignment with Washington 1427 and the CDC. So we have had clinics who have taken this table and sort of made it their own, and it's sort of like a one-page sort of cheat sheet for when a patient comes in to sort of have a sense of what they need to be doing. And then finally, these resources for practice facilitators or coaches or quality improvement staff, et cetera. These are, if you are wanting to do the 6 building blocks program or help a clinic do this, there are tons of tools here, and these are organized by the stage. And each stage, I'll highlight, has a workbook that walks the practice facilitator or the coach through the steps of helping a clinic, supporting a clinic doing this work. And many other resources are here as well. And then finally, the last page is just about us and where this all came from and who was a part of it. And there is an email address here, 6bb@uw.edu, if you have questions, but also you're welcome to reach out to me. And then I am going to continue. Oh, let me get to the slide. In addition to the website, we often connect clinics that we work with to the University of Washington Telepane. Hopefully some of you have heard of this before and have taken advantage of it. But here at the University of Washington, they host every Wednesday from 12 to 1:30 these Telepane sessions. So what's included in those are didactic presentations about caring for patients with chronic pain, and then they also have case presentations from community clinicians, like some of you on the call perhaps, where a clinician has a challenging case. They're not really sure what the best next steps might be, and so they're able to do a presentation, and the interprofessional panel of specialists talks through with them what viable next steps might look like. These are really, really helpful. We've heard great feedback from folks who have participated, not just clinicians, but also staff. It's amazing how much staff have valued the opportunity to learn more about what's going on with these patients with chronic pain. So I highly recommend you take part. We also at the University of Washington have a pain and opioid hotline that you can call if you wanted to talk through a case with a consultant. And they're available Monday through Friday from 8:30 to 4:30. There's the phone number. Here is Laura May and my contact information. If you want any more information from us or you have questions, please do not hesitate to reach out. We're happy to help. And we'd love to take questions now if you have any. Amanda, how should we handle questions? Were they going to use the chat?
Yep, so if you have questions, go ahead and type them into the chat box. As I mentioned earlier, if you would like to share them without everyone else seeing, feel free to just chat them directly to me at admin, and I will read them out. Okay, so a question about the website. Is the website best used for a coach or for clinic staff?
Either coaches or staff or clinicians, anyone would find tools and useful information on the website. It really just depends, and that's why we organize those resources into the different categories. So if it was someone who is hoping to coach and support a clinic in doing the work, then the practice facilitator resources are really helpful. But the clinic resources and the recommended assessments pages, we've had many clinic staff take advantage of those tools and find them useful.
Great, thank you. Yeah, listening to Laura May's presentation, I was thinking about wondering if there was example policies that clinics could use, and I was excited to see when you went through the website that that was available. I think that would be really helpful for our partners.
Great.
So another question, and Laura May, this might be for you, but at what point in patient care are patient agreements typically introduced?
Yeah, so and I just want to mention one thing about the patient agreement. We also have patient agreements that align with our model policies. So we have a model patient agreement and a model policy on our website. So you can look for both of those. The patient agreement is used for individuals who are identified as using long-term opioid therapy. So I know that many of you may be familiar with the 1427 rules that have come out this year, and the fact that there are now sort of 3 phases of opioid use that are included in those 1427 rules, sort of acute, subacute, and chronic. And so I would say that once a patient has transitioned to using long-term opioid therapy, that would be the time at which most clinics choose to implement their patient agreements. And one of the things that I'd like to say about the patient agreement that I think is really important and is a shift, these used to be called, for the most part, patient contracts. And we've shifted from that language because we believe that the patient agreement is really a wonderful opportunity to kind of share, have a conversation with the patient about opioids, to do that risk-benefit analysis, to share information that the patient may not be aware of about what the risks and what the potential benefits of the opioids are, and why an agreement like this is put into place. And so we don't see it as much as a contract, but rather as a conversation starter and a conversation initiator. So I hope that answers the question.
Great, thank you. We have a question about the opioid improvement team. So who besides the clinic lead is typically on those teams?
Do you want to take that, Brooke? Or?
Sure. It's really up to the clinic what makes the most sense for them, and who's generally involved in these kinds of quality improvement programs, and who also really has passion for the work and caring for these patients and making changes. Generally, there is a clinician who is a champion, who really is a connection to the other clinicians in the practice and is able to speak on behalf of the work at provider meetings. And then there is someone who is sort of the project management of the quality improvement work, who could be anyone from a clinic manager or someone with quality improvement experience, or we've had a vast range of folks in that position. And then generally there's someone who can help out with the building of the tracking and monitoring system, so someone who helps build programs within the EHR and can work with the data. We've also had pharmacists on the team, which can be very helpful, particularly around identifying OUD patients, et cetera, like working on some of that. And we always encourage that there's representation across roles in the clinic, because this is team-based care. We want to make sure that there's a voice for the different roles. So usually a medical assistant is on the team as well. Laura May, am I forgetting anybody?
No, I think.
As well.
I'm sorry. Say that again.
Sometimes, particularly recently, there's been more interest in putting like a patient representative on the team as well, which is interesting.
Mm-hmm. Yeah, and some clinics have smaller opioid improvement teams. Others have many people on their opioid improvement teams. We've been really amazed at the variation between clinics. We find that those teams meet at least monthly on their own to move the work forward. Most teams actually initially meet even more than once a month to move the work forward. And so the larger the team, the more difficult it is to get that entire team together. So if a clinic has chosen to have a larger opioid improvement team, often they'll choose kind of a smaller executive team that will do work in between the times that the larger group can get together to really make sure that progress is made, because sometimes when you have too large a team, it's hard to make the progress in a timely fashion.
So we have a question here from Cedric about, do you recommend using an outside coach, and is a practice coach available from UW? So Laura, May, will you just answer that last piece, is a practice coach available from UW, and then I can talk about how the ACH is thinking about practice coaches as
well. Yes. Well, as you can see, we have 2 expert practice coaches that work with a variety of different practices. We are actually working directly with practices in another accountable community of health and have a relationship with them to conduct that coaching. So yes, our coaching team is available to provide practice coaching. Your ACH has been thinking about this as well, and so maybe I'll turn it over to you, Amanda, and you can talk a little bit more about that. And we can also just have a dialogue about that.
Great, thank you. So something our opioid team at the ACH has been thinking about is using some ACH funds to hire a practice coach in the North Sound region that might be based at one organization but can provide practice coaching across organizations. And it might not be I don't think it would be a full-time position for any one clinic, but across all of our partners who are working on the 6 building blocks, we could do like a collaborative sharing of a practice coach. And that's definitely still in the ideas phase. And I think, following up from our site visits that we had last month, that we will be reaching out to all the folks who are in various stages of implementing 6 building blocks and probably getting some feedback from you all about what would be helpful. And that's one of the ideas that we had in thinking about how to provide practice coaching to clinics in our region.
And one thing I might mention about that is we really love the idea of more practice coaches well trained in the 6 building blocks being out in the world, because obviously our team cannot scale up and spread to every clinic there is in the country or in the nation. And so we've actually received some funding and we're in the middle right now of a practice coach training program that we have developed. And so because having an external coach, and when I say external, I just mean having a designated coach for this work, we have heard from our practices over and over again is really important, because as you can imagine, taking on this work on your own and kind of moving the work forward can be hard. You've got a lot of competing priorities. And so having a coach who's kind of helping keep practices and organizations on track, providing resources when they're needed, kind of troubleshooting and brainstorming and helping identify solutions has been just invaluable. A lot of clinics have said to us, we love the accountability of having a coach. So like I mentioned, we actually do have a program in which we are able to train. We've been thinking a lot about how to train practice coaches effectively, including potentially some shadowing of our coaches with a new coach to be able to do that work. So we've been thinking a lot about that strategy as well.
And do you know how long that training will be, or if there's a cost associated with it?
Well, yes, there is definitely a cost. We've been actually identifying sort of what the cost would be of a program like that, and we have several different models, and we can talk more about what that would look like. Right now, we have a group model where we have coaches from actually across the country that are coming into this coach training program that we have, are halfway through right now. So there are also economies of scale in linking with other programs. We know, for example, that the program, the Greater Columbia program, has a couple of practice navigators that they're very interested in learning as well. So it may be that other ACHs could come together and actually get trained simultaneously. So I think there's lots of really interesting possibilities, and I love the idea of training across ACHs because that would really spread the wealth.
Definitely. And the duration of the training?
Yes, sorry. So it kind of depends. I think it can be tailored. We have developed a year-long training program as well as a 6-month. Obviously, this work takes, 15 months, so it's really ideal, depending on how you do it, that the coaches can get support over the course of their first training experience. So I think ideally it would be where our training program would actually mirror, right, the implementation program over the year. Over roughly a year. It would be more intensive at the beginning in the first 6 months and then less intensive over time. But, one of the things that you can see from the program is that we do these shared learning calls. We have a lot of resources, and things change over the course of the program. So the issues that come up at the very beginning when you're first preparing and launching are very different than when you're in that redesign program. So being able to receive support throughout that time frame, I think, is ideal. But that's something that we could, have a conversation about.
Yeah, and as I mentioned, we at the ACH will be reaching out to our partners who are committed to the 6 building blocks and kind of hearing from them as well what would be helpful. And I think between the 3 groups, ACH, our partners, and you guys, we can find something that will work well.
Yeah, absolutely.
So a couple other questions. Do the building blocks have to go in chronological order?
Go ahead and take that, Brooke.
Okay. No, not at all. In fact, generally, clinics are working on parts of multiple building blocks at the same time. As Laura May mentioned, after the stage where the clinic is spending some time to really figure out where you're starting from and what your priorities are, then in the second stage, design and implement, you're putting those into place. And clinics tend to start with revising their policies because it is sort of a foundation, almost a vision statement for what you want to be doing, and then start to work on workflows and patient agreements to support that. Alongside that work, clinics are generally working toward building their tracking and monitoring approach because it does take a little time and iteration to make it what they want it to be. But really it is up to the practice to identify which of the activities within each building block are the priorities. And so the activities I'm mentioning are, when we are on that implementation page, there were a list of activities that tend to take place within each stage and under each building block. And so it's up to the clinic, and it doesn't need to go in the building block order because they're not actually ordered. They're a set of approaches and system-based changes that together improve care for patients with long-term opiate therapy.
Great, thanks, Brooke. So there's a question about, Laura May, you had mentioned teams moving into other work beyond the 6 building blocks, and this person's wondering if the practice facilitator can support that work as well.
Yeah, so we have not, our practice facilitators have focused on the 6 building blocks. But what we've heard clinics say is sometimes that, particularly we remember that we worked with rural clinics, very rural clinics that had not had a huge amount of quality improvement experience. So what they said to us is, we're using the 6 building blocks as a way of learning how to do a well sort of designed quality improvement project. And so the kinds of steps that the 6 building blocks involved can be translated into other quality improvement initiatives. And clinics have really appreciated having that experience in that way. But our coaches have worked exclusively with the 6 BBs. That said, if you hired a coach and your coach did their first coaching experience with the 6 building blocks, they would have those experiences and kind of the sequences and tooling to work on other projects that you might want to work on.
Great, thank you. And then just one last question for now. We have about 5 minutes, so anyone, if you have some last minute questions, feel free to chat those in. Just a point of clarification. This person said that you mentioned coach and practice facilitator. Are those just interchangeable titles for the same role, or are those different roles?
That's a great question.
That is a great
go
question.
ahead.
Those are interchangeable titles for the same role. Within the quality improvement community, both are used, and so we tend to throw them both around. But thanks for that clarifying question.
Yeah, I don't know. Facilitator always sounds so clinical to me, and coach sounds more familiar. So I tend to use the word coach, but I think in the literature around this work, they tend to use the word facilitator. So that's why it's confusing. Sorry about that.
That's okay. Thanks for clarifying. So we have one other question I think is actually directed towards ACH staff, a question about how can they learn which clinics are using the 6 building blocks model. And I think that is some internal communication we can do at the ACH, and we'll be sure to share out with partners which other partners in our area are committed to those efforts. So if that is it for the questions, we do have a evaluation for this webinar. If you wouldn't mind filling it out, I'm going to type it into the chat box, and then these slides will be, these slides as well as the recording will be posted to the partner portal. And if you have any questions, do feel free to reach out to us at the ACH or to Dr. Baldwin and Brooke. Next week, we are having a webinar on Dentist Link, and it'll be our regular Wednesday at 10 a.m. time. The following week will be All Payers Claims Database, and then on September 4th, we will have a webinar on Upstream. So thank you for joining us today, and Dr. Baldwin and Brooke, it was really great having you, and I think there's a lot to look forward to in working together.
Yeah, thank you.
Yes, thank you so much. It was really a great experience. Sorry we couldn't talk to you, but lovely to chat in the way that Zoom allows.